including pathogenesis, clinical findings, and treatment. Question 1. Pathophysiology. A 56-year-old man with a history of poorly controlled type 1 diabetes is brought to the emergency department with altered mental status. Examination reveals a black eschar on the nasal mucosa and periorbital swelling. A biopsy shows broad, ribbon-like, non-septate hyphae with irregular branching. Which of the following best explains the pathogenesis of this infection? A. Toxin-mediated disruption of host protein synthesis. B. Fungal invasion of alveolar macrophages. C. Angioinvasion leading to tissue necrosis. D. Type 1 hypersensitivity reaction in bronchial mucosa. E. Spore phagocytosis followed by lymphatic dissemination. Correct answer C. Angioinvasion leading to tissue necrosis. Explanation: Mucor and Rhizopus SPP invade blood vessels, thrombosis, ischemia, tissue necrosis, especially in DKA patients. Infections often start in nasal sinuses, spreading to brain via cribriform plate. Incorrect options: A. Toxins not the primary mechanism in mucormycosis. B. Describes histoplasma. D. Describes allergic bronchopulmonary aspergillosis. E. Not typical of mucor spread. Question 2. Clinical recognition. A 49-year-old man with acute myeloid leukemia undergoing chemotherapy develops fever, facial swelling, and right periorbital pain. Nasal endoscopy shows necrotic tissue. Biopsy reveals broad non-septate hyphae branching at wide angles. Which of the following organisms is most likely responsible for this patient's condition? A. Aspergillus fumigatus. B. Candida albicans. C. Cryptococcus neoformans. D. Rhizopus species. E. Histoplasma capsulitum. Correct answer D. Rhizopus species. Explanation: Rhizopus and Mucor species. Broad, non-septate hyphae, wide-angle branching, typically seen in immunocompromised or DKA patients, associated with rhinocerebral mucormycosis. Question 3. Treatment strategy. A 60-year-old man with diabetic ketoacidosis develops invasive sinus infection with orbital swelling and cranial nerve deficits. A diagnosis of mucormycosis is confirmed on histopathology. What is the most appropriate next step in management? A. Oral fluconazole. B. Nystatin mouthwash and observation. C. High-dose intravenous voriconazole. D. Surgical debridement plus amphotericin B, caspofungin plus corticosteroids. Correct answer D. Surgical debridement plus amphotericin B. Explanation: first-line therapy for mucormycosis equals urgent surgical debridement, IV amphotericin B, or isavuconazole. Delay in treatment, mortality. Incorrect options: A. Fluconazole ineffective against mucorales. B. Nystatin is for superficial candida, not systemic infection. C. Voriconazole is ineffective for mucor. E. Caspofungin doesn't cover mucor. Corticosteroids would worsen it. Let me know.